Imagine for a moment the real challenge of just trying to breathe, that desperate, almost gasping struggle for air.
Yeah, it's a terrifying feeling.
And when we think about medical help for breathing, our minds often jump straight to those really invasive machines, right? Tubes going directly into the airway.
Mm-hmm. Endotracheal tubes, tracheostomies,
Mm-hmm.
often needed for weeks.
Exactly. But what if there was another way, a powerful way to provide that critical breathing support to ease that struggle, but without needing an artificial airway?
That's precisely where non-invasive ventilation comes in.
Right. So today we're doing a deep dive into exactly that, non-invasive ventilation, or NIV. We've gathered insights from medical handouts, research papers, trying to give you a really comprehensive picture.
Yeah, looking at how it works, who it helps.
And why it's really become such a game changer in respiratory care. So let's start right at the beginning. What exactly is non-invasive ventilation?
Okay. Well, at its core, NIV delivers that crucial breathing support, but without needing an invasive artificial airway.
Meaning no tubes down the throat or in the neck.
Precisely. No endotracheal tube, no tracheostomy tube. And the real genius, I think, is that it helps avoid so many of the complications tied to those more invasive methods.
That's a huge distinction right off the bat, isn't it? Avoiding those tubes must completely change the patient experience.
Absolutely. It's less traumatic, generally more comfortable.
And historically, we've seen a couple of different ways to approach this kind of non-invasive support, haven't we?
We have. You can think way back to things like negative pressure ventilation.
Ah, like the old iron lung.
Exactly. The iron lung, the rocking bed, even things like the chest cuirass. These older devices worked by creating negative pressure around the body or chest to sort of pull air into the lungs.
Interesting. But that's not what we typically see now.
Not usually, no. Today, the vast majority of NIV uses positive pressure ventilation.
Okay, positive pressure. How's that delivered?
It's typically delivered through a mask.
Right.
That might be an oronasal mask, which covers the nose and mouth, or maybe just a nasal mask, or sometimes even a full face mask covering everything.
So the modern approach is positive pressure, usually through a mask. And the real aha moment here isn't just avoiding the tubes, right? It's the knock-on effects.
Exactly. You think about the common problems with traditional ventilation, serious infections like VAP, ventilator-associated pneumonia.
Right, VAP, a big concern.
Prolonged hospital stays, muscle weakness from being stuck in bed. NIV can dramatically cut down these risks. It fundamentally changes the patient's recovery path.
That initial difference, no invasive tubes, it really sets the stage for why NIV is such a vital alternative.
Yeah.
It helps sidestep those common complications.
Definitely.
So thinking bigger picture now, what are the main goals clinicians are aiming for when they use NIV? Do they differ depending on the situation?
They do, yeah. The goals shift a bit depending on the context. So in an acute care setting, think short-term urgent situations like in a hospital.
Okay.
The primary objective of NIV is really to improve the patient's gas exchange.
Getting more oxygen in, more carbon dioxide out.
Precisely. And doing that without having to resort to endotracheal intubation.
And just avoiding intubation itself is a huge win, but there are other benefits too, right, in that acute setting?
Oh, absolutely. Beyond just avoiding the tube, NIV in acute care aims to decrease mortality rates, reduce the total time a patient needs ventilation support.
Makes sense.
Shorten their hospital stay, and significantly lower the risk of VAP, that nasty ventilator-associated pneumonia.
Okay.
And it's also about relieving those immediate symptoms of respiratory distress. Making breathing feel easier, improving how the patient's own breathing syncs up with the machine.
Patient-ventilator synchrony, right.
Exactly. And ultimately, maximizing their comfort during what's often a really stressful, vulnerable time.
That sounds incredibly important for those acute situations. But what about patients with chronic conditions? Maybe they're using NIV long-term, perhaps at home. The goals must be different then.
You're spot on. In those chronic long-term care settings, the focus really shifts towards sustaining the patient's well-being over time.
So less about immediate crisis management, more about quality of life.
Precisely. The goals become relieving or improving persistent symptoms, significantly enhancing their overall quality of life, helping them avoid repeated hospitalizations.
That's huge, keeping people out of the hospital.
It is. And also increasing their long-term survival and even improving their mobility and daily function.
So connecting this to the bigger picture, NIV isn't just a breathing machine in those cases.
Not at all. It's really a more holistic intervention. It prioritizes patient comfort, it minimizes risks, and it empowers people to maintain a better quality of life, often by preventing those destructive hospital stays.
Okay, so given these different goals for acute versus long-term care, it brings up a really important question. Who is NIV actually for? Who are the ideal candidates, and how do clinicians figure that out?
Right, and this is where the precision of NIV really comes into play. It's not for everyone. In acute care, it's often the first-line therapy for something called hypercapnic respiratory failure.
High CO2 levels.
Exactly. Especially during a bad flare-up of COPD, chronic obstructive pulmonary disease, particularly if the patient's blood pH, their acidity, is still somewhat manageable, say 7.25 or higher.
So COPD is a big one for acute NIV. What else?
It also plays a role in managing severe asthma attacks, and it's a key treatment for acute cardiogenic pulmonary edema, ACPE.
That's fluid in the lungs from heart failure.
Right. In that case, we often use CPAP, continuous positive airway pressure, at specific settings to help push that fluid back out of the air sacs. For other types of acute respiratory failure, maybe where the main problem is just low oxygen, hypoxemic failure, it's used a bit more cautiously.
Are there other acute scenarios where you might see NIV?
Yeah, definitely. It's valuable for patients with weakened immune systems who develop respiratory failure. It can help patients recover after surgery, avoiding breathing complications.
Post-op.
And crucially, it's used to help wean COPD patients off invasive ventilation facilitating extubation, or to prevent reintubation in high-risk patients after their breathing tube comes out.
Preventing them from needing the tube put back in.
Exactly. And, perhaps quite profoundly, it plays a big role in end-of-life care.
How so?
For patients who have do not intubate, or DNI orders, or comfort measures only, CMO orders, NIV can offer vital symptom relief, easing the work of breathing without prolonging suffering through really invasive means.
That's a really important application. So, okay, beyond the specific diagnosis like COPD or ACPE, what are the actual signs a clinician looks for in a patient to say, yes, this person might benefit from NIV right now?
They look for clear signs of respiratory distress. That could be seeing the patient use extra muscles in their neck or chest to breathe.
Accessory muscle use.
Right, or a paradoxical breathing pattern, where the belly sucks in when they inhale instead of moving out. Also, a fast breathing rate, usually over 25 breaths per minute, or just moderate to severe shortness of breath dyspnea.
And it's not just physical signs, right? Blood tests, too.
Correct. Alongside those physical signs, they assess blood gas levels. They're looking for moderately abnormal gas exchange. Maybe a PaCO2, that's carbon dioxide in the arterial blood, over 45 with a low pH under 7.35.
Indicating acidosis?
Yes, respiratory acidosis. Or maybe a low PF ratio, which compares oxygen levels to the amount of oxygen being delivered, indicating significant lung strain.
Okay, that covers the acute side. Who are the typical candidates for long-term NIV, often used at home?
For long-term care, NIV primarily targets what we call nocturnal hypoventilation.
Under breathing during sleep.
Exactly. And this is often associated with chronic conditions. Think restrictive thoracic diseases, where the chest wall or lungs can't expand properly.
Like scoliosis or certain muscular dystrophies.
Yes, conditions like that. Also, ALS, amyotrophic lateral sclerosis, and stable COPD patients who have chronically high CO2 levels even when they're not acutely ill.
Okay.
And a big one, increasingly common, is obesity hypoventilation syndrome, or OHS.
OHS. What defines that?
OHS is characterized by chronic daytime hypercapnia. So, persistently high CO2 levels during the day, combined with sleep-disordered breathing and obesity, usually BMI over 30, but importantly, when there's no other explanation for the hypoventilation.
Got it. And for someone with OHS or maybe one of those restrictive conditions, what symptoms would make a doctor think about long-term NIV?
Patients often present with symptoms really linked to that poor breathing during sleep. Things like shortness of breath during normal daily activities, orthopnea, which is difficulty breathing when lying flat, poor sleep quality, waking up a lot, morning headaches.
Headaches, interesting. Why is that?
It's often due to the buildup of CO2 overnight. Also, persistent daytime fatigue or sleepiness, even after full night's sleep. Maybe a decrease in energy or concentration.
Right.
Sometimes recurrent problems like hospitalizations or frequent chest infections, and eventually even signs of cor pulmonale, which is right-sided heart failure caused by the lung disease.
Wow. So understanding these specific criteria, both acute and chronic, really shows how carefully NIV needs to be applied.
Absolutely. It ensures it's the right fit for the patient's specific condition and what we hope to achieve.
Okay, so we know who can benefit. Just as critical as knowing who cannot or really should not use NIV. When is it definitely the wrong choice, particularly in that acute setting?
Yeah, there's some clear exclusion criteria. For instance, if a patient is actually in apnea, meaning they've stopped breathing altogether, NIV isn't going to work. They need intubation.
Makes sense.
Also, if they can't protect their own airway, if they have a depressed level of consciousness or poor cough or a gag reflex, the risk of aspirating stomach contents into their lungs is too high.
Aspiration risk. Okay, what else?
Hemodynamic or cardiac instability. So really unstable blood pressure or dangerous heart rhythms. A lack of patient cooperation is a big one. They have to tolerate the mask.
Right, if they keep pulling it off.
Exactly. Or if they physically can't use an interface because of, say, facial burns, major trauma, or some kind of anatomical abnormality.
Yeah.
And definitely if they have excessive secretions, like lots of phlegm they can't clear, that could obstruct the airway or be aspirated.
That inability to protect the airway sounds like a pretty firm no. Is there any situation where a clinician might push that boundary a little, or maybe a known exception?
That's a really sharp question, and actually, yes, there is one significant exception that's really changed practice over the years. For COPD patients who are having that hypercapnic flare-up high CO2, even if they have a somewhat decreased level of consciousness.
Which normally would be an exclusion.
Which normally would be, yes. But studies have actually shown that in this specific group, using NIV can lead to fewer intubations, lower mortality risk, fewer complications overall, and shorter hospital stays.
Wow. So the benefit outweighs the risk in that specific case.
Potentially, yes. But it requires extremely close monitoring, obviously. It's a nuanced decision.
Fascinating. Okay, so let's say NIV is started. What are the immediate signs clinicians look for, early on to know if it's actually working? Are there quick predictors of success?
Absolutely. Especially in acute care, you want to see positive signs pretty quickly. Key predictors of success include having a minimal air leak around the mask.
So a good seal is important.
A reasonably good seal, yes. And generally, a lower overall severity of illness tends to predict better outcomes. From the blood gas side, they look for a specific pattern of respiratory acidosis. PaSO2 is high, pH is low, but not critically so. There's sort of a sweet spot.
Okay.
But most importantly, clinicians look for a rapid and significant improvement in the patient's condition within the first 1 to 2 hours.
What kind of improvements?
Improvement in their gas exchange on repeat blood tests, a slowing down of their respiratory rate and their heart rate coming down. Seeing those key physiological markers improve quickly is a really powerful sign that NIV is likely to be successful for that patient.
Okay, we've really laid the groundwork, what NIV is, why it's used, who it's for, who it's not for. Now let's pull back the curtain a bit on the actual mechanics.
The nuts and bolts.
Exactly. Specifically, the two main types of positive pressure NIV we hear about most, CPAP and BiPAP. This is where it gets really interesting. Understanding how they actually support breathing. What's the core difference?
Great question, because they are distinct, even though both are forms of NIV. Let's start with CPAP. That stands for continuous positive airway pressure.
Okay, continuous.
Right. Think of CPAP as providing a constant, gentle pressure, like an air splint throughout the entire breathing cycle, both inhalation and exhalation.
So the pressure doesn't change?
Correct. The pressure stays the same. Importantly, with CPAP, the patient does all the work of breathing. The machine doesn't give mechanical breaths. It just holds the airway open.
Like preventing collapse.
Exactly. It's primarily used to treat airway obstruction. Classic example is obstructive sleep apnea, and to improve oxygenation by keeping those tiny air sacs, the alveoli, open. But it doesn't actively assist ventilation, meaning it doesn't help blow off CO2 or reduce the work of breathing itself.
Okay, so CPAP is like propping the door open so air can get in and out more easily, mainly helping with oxygen and blockages, but it doesn't actually push the air in for you.
Precisely. That's where bilevel PP comes in.
Bilevel, meaning 2 levels.
Exactly. Bilevel positive airway pressure, often known by the common brand name BiPAP, provides 2 distinct pressure levels.
Ah, okay. How does it work?
It delivers a higher pressure during inhalation that's called IPAP, inspiratory positive airway pressure, and then cycles down to a lower pressure during exhalation, that's EPAP, expiratory positive airway pressure.
So high pressure going in, lower pressure going out.
Right. And it's this difference between the IPAP and EPAP, this pressure gradient, that actually assists the patient's breathing. It helps them take a bigger breath in and makes it easier to breathe out against the lower pressure.
So BiPAP actively helps with the work of breathing.
Yes, it helps increase the volume of air moved with each breath, which helps lower CO2 levels, that's improving ventilation, and it reduces how hard the patient's respiratory muscles have to work.
Let's break down those pressures a bit more. IPAP, the inspiratory one, what's its main job?
IPAP primarily controls the peak pressure during inspiration. So you increase the IPAP, you generally increase the tidal volume, the amount of air inhaled, which helps blow off more CO2 and improves ventilation.
Okay, so IPAP is key for ventilation for CO2 removal. What about EPAP, the expiratory pressure?
EPAP controls the pressure remaining in the airways at the end of expiration. Its main role is similar to what PEEP does in invasive ventilation.
PEEP, positive end expiratory pressure.
Right. EPAP helps increase the lung volume at the end of the breath, the functional residual capacity, or FRC. It does this by recruiting or opening up collapsed alveoli, those tiny air sacs.
It's improving surface area for gas exchange.
Exactly. That improves the matching of ventilation and blood flow VQ matching, and ultimately enhances oxygenation.
So EPAP is more about oxygenation and keeping alveoli open, while IPAP is more about driving ventilation and reducing CO2.
That's a great way to summarize it. And interestingly, if you set the IPAP and EPAP to the same level,
then it's just like CPAP.
Precisely. It just delivers one continuous pressure. But in BiPAP mode, IPAP is always higher than EPAP.
Got it. And what about the machines themselves? Are we talking about the big, complex ICU ventilators, or are there specific NIV machines?
There's a range. There are dedicated non-invasive ventilators, often electronically powered, microprocessor controlled. They're designed specifically for NIV, often using a simpler single-limb circuit that has an intentional leak built in for exhaled gas to escape.
Okay.
But your standard critical care ventilators, the ones you see in the ICU, can also be used for NIV. They usually have specific non-invasive modes built in. They might use a double-limb circuit for more precise monitoring and control.
More sophisticated, perhaps?
Generally, yes. And then you also have portable home care ventilators, or transport ventilators, which are smaller, often battery-powered, designed for use outside the critical care setting.
So a variety of devices. But the core difference in function between CPAP and BiPAP is key.
Absolutely. CPAP is that continuous airway splint, mainly for oxygenation and obstruction. BiPAP actively assists the work of breathing with its two pressure levels, really helping with ventilation and CO2 removal. Understanding that difference is fundamental to choosing the right therapy.
Okay, so this pressure support, whether it's CPAP or BiPAP, sounds incredibly helpful, but how does it actually get to the patient? It has to connect somehow. That brings us to the interfaces, right? The masks, the pillows.
Yes, the interface is absolutely critical. It's the direct link between the machine and the patient, and if it's not right, the therapy won't be effective or tolerated.
What are the most common types you see?
Well, there are several options, but the two real workhorses, especially in the hospital setting, are the oronasal mask and the nasal mask.
Oronasal, that's the one covering nose and mouth.
Correct. The full face mask, basically. It's often the best choice initially for acute respiratory failure because it tends to be easier to get a good seal, which is vital for delivering the pressure effectively.
Makes sense. Easier seal. Any downsides?
Oh, definitely. They can feel quite claustrophobic for some patients. Compliance can be an issue. And there's a higher risk of aspiration if the patient vomits because it's harder for it to escape. So having good alarms and monitoring is crucial.
Claustrophobia and aspiration risk. Okay, what about the nasal mask then? Just over the nose.
Right. The nasal mask is also very common and often preferred for longer-term use or if claustrophobia is a major issue. Patients often find it more comfortable.
Better compliance, maybe?
Often, yes. But the downside is that it's more prone to air leaks, especially if the patient breathes through their mouth. It can also cause nasal dryness or congestion. A common mistake is picking one that's too big, though a small leak isn't always a disaster if breathing is okay.
So oronasal for maybe a better seal acutely, nasal for potentially better comfort long-term. What else is there?
You also have nasal pillows. These are small cushions that fit directly into the nostrils.
Oh, like little plugs.
Kinda, yeah. They're often very comfortable, especially for CPAP users, like for sleep apnea at home. But they're not great for delivering really high pressures, and leaks can still be an issue, sometimes needing a chin strap to keep the mouth closed. They aren't usually seen as effective as masks for BiPAP in acute settings.
Okay. Pillows for lower pressures. Anything else?
There are also hybrid masks. These try to combine features. For example, a mask might cover the mouth, but use nasal pillows for the nose, or maybe a soft silicone flap seals around the nostrils.
What's the advantage there?
The idea is often to get a good seal with fewer leaks, reduce skin breakdown on the bridge of the nose, maybe feel less claustrophobic, and sometimes even allow the patient to wear glasses during therapy.
It sounds like choosing the right interface is a bit of an art and definitely involves troubleshooting. What are the most common problems clinicians run into with these masks?
You're absolutely right. Finding the right fit and managing side effects is key. Air leaks are probably the number one issue.
Leaks around the edges.
Yeah. Solutions involve adjusting the headgear straps not too tight, not too loose, Maybe adding spacers or foam pads over pressure points like the bridge of the nose. Sometimes a chin strap helps with mouth leaks when using a nasal mask. Or you might just need to try a different size or even a completely different style of mask.
What about other common complaints, like irritation?
Skin breakdown or irritation is a big one, especially on the nose bridge. Again, adjusting fit, using pads, maybe a barrier cream or specific dressings, ensuring the mask is cleaned properly, but also that the cleaning solution isn't causing irritation. Sometimes changing mask type helps distribute pressure differently.
And the airflow itself can cause issues, right? Like dryness.
Yes, nasal congestion or dryness is very common. Adding heated humidity to the circuit is often the best solution. Encouraging fluid intake, using saline nasal sprays or water-based lubricants can also help. Sometimes adjusting the pressure settings might be needed too.
It really highlights how crucial comfort and fit are. If the patient can't tolerate the interface, the whole therapy fails.
Exactly. So the big question is always, how do we ensure comfort and compliance when the interface is so central to an IV's success? It's often this delicate balance, finding the right device, managing those inevitable minor side effects proactively, and really educating the patient about what to expect and how to manage it.
Okay, so let's say we've found the right interface. It fits reasonably well. How do clinicians actually set the machines? It's clearly not just flicking a switch. How do they determine the right pressures?
Absolutely not random. It's a very precise process, and it depends on whether you're using CPAP or BiPAP and what the goal is. Let's start with CPAP.
Okay, CPAP, continuous pressure, mainly for oxygenation and obstruction.
Right. So the initial pressure setting is typically quite low, often starting around 5 centimeters of water pressure, maybe 3 to 5 centimeter H2O.
Pretty
relatively, yes.
right.
Then, the main thing to adjust is the FiO2, the fraction of inspired oxygen, basically the percentage of oxygen in the air being delivered. You titrate that up or down to get the patient's oxygen saturation, there's PO2, into the target range, usually somewhere between 88% and 95%.
So for CPAP, set a starting pressure, adjust oxygen. Simple enough. BiPAP must be more complex with its 2 pressures.
It is a bit more involved, yes. For BiPAP, you have 2 pressures to set, EPAP and IPAP.
Right, expiratory and inspiratory.
The EPAP, the expiratory pressure, is often started around 5 to 8 centimeter H2O. Remember, this helps with oxygenation and keeping airways open.
Okay, 5 to 8 for EPAP, then IPAP.
The IPAP, the inspiratory pressure, is then set above the EPAP, often starting maybe 2 to 5 centimeter H2O above EPAP initially, and then commonly needing to be increased to maybe 8 to 12 centimeter H2O higher than the EPAP.
So there's always that gap between them.
Yes, that pressure difference is what drives the ventilation. The goal is often to achieve a good spontaneous tidal volume, the amount of air the patient breathes in with each assisted breath, usually aiming for around 5 to 8 milliliters per kilogram of their ideal body weight.
And oxygen for BiPAP.
Same principle as CPAP. You adjust the FiO2 to keep the oxygen saturation in that target range, 88 to 95%.
Is there anything else set on BiPAP?
Often, yes. There's usually a backup respiratory rate set, maybe 8 to 12 breaths per minute. This is just a safety net. If the patient's own breathing rate drops too low, the machine will deliver a breath.
Okay, that makes sense. Now, we talked about troubleshooting the masks. What if the machine seems to be the problem, say with CPAP? Are there common machine-related issues?
Sure. If you suddenly see the pressure drop right down, the first thing you suspect is a disconnection somewhere in the circuit or maybe a break.
Check the connections.
Always. Another issue. If you notice the CPAP pressure dipping significantly every time the patient inhales, maybe dropping more than 2 centimeter H2O.
What does that mean?
It usually means the flow from the machine isn't keeping up with the patient's demand. They're pulling harder than the machine is delivering. The solution is typically to increase the flow setting on the device. You might also see the patient using accessory muscles more or complaining they feel like they're working harder to breathe.
And the opposite, too much flow.
Yes, if the pressure seems inadvertently high or the patient complains it's hard to exhale, the flow might be set too high and you'd need to decrease it. And a couple of other little things. If a water-based humidifier is used, the pressure can drift down as the water evaporates.
Need to keep an eye on the water level.
Exactly. And some older systems used a ball-bearing resistor. Those had to be kept perfectly vertical, or you'd lose all the pressure.
Good to know. Okay, so CPAP has its quirks. What about adjusting BiPAP once it's running? You've got 2 pressures to play with.
Right. A key concept here is the difference between IPAP and EPAP. We call that the delta P, or sometimes just pressure support.
Delta P, the gap between the 2 pressures.
Exactly. And that delta P is what primarily determines the amount of ventilatory assistance, how much CO2 is removed.
So if you need more ventilation, maybe the patient's CO2 is still too high. How do you adjust?
You need to increase that delta P.
Yeah.
You can do that primarily by increasing the IPP.
Higher inspiratory pressure pushes more air in.
Right. Or you could potentially decrease the EP, although that might affect oxygenation. Other factors influencing ventilation are lung compliance, how stretchy the lungs are, and airflow resistance. Improving those, if possible, also helps.
Okay, so increasing IPAP boosts ventilation. What if the main problem is oxygenation? Maybe the SpO2 is still low.
If oxygenation is the main issue, the key pressure to adjust is usually the EPA.
Increasing the expiratory pressure.
Yes. Increasing EPAP helps recruit more alveoli, improves that FRC and VQ matching we talked about, and boosts oxygenation. But here's the important part.
Yes.
If you increase the EPA to improve oxygenation, you generally need to increase the IPAP by the same amount to maintain the same level of ventilation support, the same delta P.
Ah, okay. So if you raise EPP by 2, you should also raise IP by 2 to keep the CO2 removal assistance roughly the same.
Precisely. Otherwise, just raising EP would shrink that delta P and reduce ventilation. And remember the rules. IPP and EPT can be the same, that's CPAP mode, but EPP can never be set higher than IP. That wouldn't make physical sense.
Got it. It really is a precise balancing act, isn't it?
It absolutely is.
Yeah.
Adjusting these pressures allows clinicians to really fine-tune the support, targeting whether the main need is for better oxygenation via EPP or more effective CO2 removal via the IPP-PAP difference, or both.
So wrapping this all together, what does this mean for you, the listener? We've taken quite a deep dive today into non-invasive ventilation. We've looked at its somewhat surprising history, its really crucial goals in different settings.
Yeah, explore the specific conditions it treats, both acute and chronic.
And gotten into the intricate details of how it actually works, from the essential masks and interfaces right down to those precise machine settings for CPAP and BiPAP.
Hopefully you now have a much clearer understanding of how NIV stands as this vital, less invasive alternative to traditional mechanical ventilation.
Right, and how it can significantly improve outcomes and, importantly, quality of life for so many patients.
We've seen those distinct but often complementary roles of CPAP and BiPAP and really hammered home why finding the right, well-fitted interface is just so crucial for the therapy to work.
So maybe the next time you hear about someone needing breathing support, you can consider the hidden complexity, but also the ingenuity behind approaches like NIV. It really is a testament to how medical tech can be both incredibly powerful and surprisingly gentle.
It truly is.
And just a final thought to leave you with. How might future advancements, maybe in wearable technology, sensors, or perhaps even artificial intelligence, how might they further revolutionize these gentle yet highly impactful interventions like NIV? Could they become even more personalized, more adaptive, more accessible in the future? Something to ponder.